Can you guys see my screen?
Yeah, very clear. Not like me. No, very clear. Yeah. So Martha was co-teaching, is it? Or Martha teaching something different?
She's teaching something different, I think.
She's teaching on Brui.
Okay.
A Brui.
Yeah, pediatric brief response.
Okay, fair enough.
Should I start?
Of course. Yeah,
Yeah.
of course you can.
Good morning, everyone. A really warm welcome to my colleagues present here for the first Caesar teaching session from Nepal, the HIEM3 colleagues. Today, I'm going to discuss about testicular pain and swelling, which is curriculum number UP4. And moving on, the objectives of this session are to discuss relevant anatomy involving scrotum, testes, and the epididymis, to learn about common causes of testicular pain and swelling presenting in the A&E, and discuss appropriate approach and management of the conditions. So regarding anatomy, the testis is oval symmetrical structure suspended by the spermatic cord in the scrotum, two in numbers. Usually the lower left testis lies lower than the right one. Anatomically, the testis is covered by two layers, bilayered tunica vaginalis, which has a parietal and a visceral layer, and is a most dependent part, usually implicated in hydrocele as well. The inner part of the testis is covered by a fibrous capsular covering named tunica albuginea. So the testis is normally in its vertical axis tilted forwards and lies laterally. And the epididymis is a highly coiled structure that extends from the posterior superior aspect of the testicle, and it has a head, a body, and a tail. It continues as ductus deferens into the spermatic cord. So the blood, talking about blood supply of the testes, the arterial supply is from the testicular artery, whereas venous drainage is from the pampiniform plexus. The left testis usually drains into the left renal vein and subsequently into the inferior vena cava, whereas the right testis drains directly into the inferior vena cava. The nerve supply is by T10 sympathetic fibers from renal and aortic plexuses, and lymph drainage is into the para-aortic lymph nodes. So the typically spermatic cord contains ductus deferens, testicular artery, cremasteric artery, artery of ductus deferens, pampiniform plexus of veins, lymphatic ducts, and nerve plexuses as well. So moving on, a 20-year-old male presents with pain in his left testicle for 1 day. On examination, there is obvious swelling of his left testicle. What could be the potential causes?
Saurab, do you want me to do the pre-course MCQ running for you now?
Yeah, that should be fine. Yeah.
So if you stop sharing up, you know.
Should I come off the screen?
Yes.
Yeah. Okay.
Testicular swelling. Okay. And I shall share my screen.
Oh, you are really in Barbados, is it?
Sorry?
Is it a background, the picture of what?
It's Trinidad.
Oh, Trinidad. Yeah. Oh, I
That's
like Trinidad.
Olu, what's the game pin?
So that's the game pin showing now.
Ah, what is this?
What's the number?
Yeah, we need the game pin code.
Yeah.
Okay.
Okay, you do it. I won't
Otherwise,
take
we can't
because-
get in, man.
Because I will fail. I will fail miserably on this. So I'm not taking part.
Saurab, of course, you're not allowed to contest.
Yeah.
Olu, what's the game pin? I can't get in.
Oh, that's the game pin. Can you see it?
No, we
Where?
cannot. Your screen's frozen.
Oh, sorry. I'm sharing the wrong screen. Sorry.
Correct. You are sharing the wrong screen. That's what I've been trying to tell you.
All right. There you go. Can you see it now?
8195883. Okay, hang on.
Can you all see it?
Can you see me? Yes, I'm in.
I'm not in.
Guys, there are 20 of us, huh?
Oh yeah.
Four people in.
Can I ask you where to put the game pin in Kahoot?
Where? So just open Kahoot and it will
Yeah.
tell you the game pin here.
Yeah, enter pin.
Just go to www.kahoot.it.
Okay.
www.kahoot.it. Then it will tell you put your game pin and it's automatic.
There is something called play. I think if we press on the play and then
Yeah.
www.kahoot.it.
Hmm.
We have 10 more seconds and I will start.
8195883.
Where's everybody else? There's like 20 people on.
Um. No.
All right, should I start now?
Yes,
Everybody ready?
yes,
ready?
ready.
No, no, I haven't gotten it.
Okay.
What? Okay. What's the problem, Patrick?
Trying to get into Kahoot.
So just www.kahoot.it.
Okay.
Go on Google or Safari.
Thanks.
So the first test is Shirish, is it? So he's done the first test, is it? Am I right?
Sorry, Mr. Julia.
So who is the first test? Who answered? Is it Shirish?
No, we've not started yet. We're waiting for everybody to log in.
Oh,
And 5, 4, 3, 2, 1. Ready? Somebody just drop it again. All right, because of time, I shall start.
Okay, let's go.
Go. The faster you answer, the more your points.
Ooh.
Okay. Next.
Everybody got wrong. Afro's
Afroza is on top. Okay. Next question. Time up. Oh, come on, guys.
Okay, all right.
Sandra.
Look at these boys.
Next.
Yay! Finally.
Okay, there's a battle. Next, ready? Whoa, boom, you made it to the top.
Hey, one more. Me and
Last
Sunda now.
one.
Me and Sunda.
Time of last one.
Number 3, Regina.
Oh,
And number 2, boom.
Yay!
And the champion.
Who's the champion?
Let's see. T-Lac.
Hey.
I was last all the time.
Runner-ups.
so Tilak will get a scrotal sport.
All right.
That
So
was fun. Right, Saurabh, let's go.
Yes. Yeah. So Olu, I think there's been a mistake on question number 2, though. The answer, yeah.
Fourniers gangrene. The blue dot is not Fourniers
That's
gangrene,
not Fournier's
bosses.
gangrene.
Yeah.
Yeah, that's what I
no,
was thinking as well.
yeah, sorry, that's torsion of the appendices.
That's
Yeah.
Yeah.
appendicular torsion. Yeah.
Yeah.
Okay.
Oh,
Anyway.
sorry, my bad.
Okay. No. Yeah.
Okay, Saurabh, let's go.
Okay. So continuing on, a 20-year-old male presents with pain in his left testicle for 1 day. On examination, there is obvious swelling of his left testicle. So what could be the potential causes? Any takers? Anyone?
Torsion.
Only-
Epididymo-ORCHITIS.
yeah.
Yeah.
Trauma.
Yeah.
Hematocele.
Hydrocele.
Yeah, that's also one of the answers.
Hematocele.
STD.
Varicocele.
Yeah.
Varicocele, yeah.
So yeah. So
Referred pain from
yeah. So the differential diagnosis would be a testicular torsion, epididymal cyst, appendageal torsion as well, a hydrocele, epididymo-ORCHITIS, as you guys have just mentioned. So we will be discussing mainly about these 5 topics today. So how do we assess a patient presenting with testicular pain? Usually historical findings are important. The history of pain is really important. We usually follow the Socrates method to again history from the patient, usually site of the pain, onset of the pain, if it's sudden in onset, if the onset was gradual, any character of the pain, any radiation towards any other parts of the body, any other associated symptoms, or any associated palliating or aggravating factors. History of associated symptoms is should also be taken. Associated symptoms could be fever, nausea, vomiting, any abdominal pains, any urinary symptoms. Mainly in adults of 18 to 35 years of age, sexual history is always very important because there are so many sexually transmitted organisms that can cause a testicular pain and swelling. And a history of trauma should also be asked to the patient. So on examination, inspection should be done to see if the lie of the testis is normal. As I mentioned earlier, the testicular lie is vertical normally. The size and symmetry of the testis should be seen, and the overlying skin should be examined for any erythema or any bruises or any other changes. And on palpation, tenderness, if the affected testes or both of the testes is tender or not. If there is swelling, then the consistency should also be noted. If the swelling is cystic in nature or if it's fixed, painless in nature, the lymph nodes around the organ should also be palpated, and the abdomen should also be palpated for any abdominal masses, because the testicular tumors usually have the tendency to metastasize to the para-aortic lymph nodes. So the lymph nodes can also be palpable, and they may also metastasize to the abdominal viscera. And any features of inguinal hernia should also be excluded through positive cough impulse test, getting above the swelling test, and any palpable bulge in the inguinal canal. Along with this, there are other signs as well, which should be examined in patients with testicular pain and swelling, some of which I have discussed below. So one of the signs is a Prehn sign. So it is usually positive, present in patients suspected to have epididymo-orchitis. It is a relief of pain on elevation of the scrotum. So this is the Prehn sign. And another reflex, this is a cremasteric reflex, which is usually mediated by ilioinguinal nerve and a genital branch of genitofemoral nerve. So how we do it is gently stroking the superomedial part of the inner thigh causes the ipsilateral testis to move forwards, move upwards. Usually movement of more than 0.5 centimeter is considered normal. This reflex is typically absent in torsion of testes. However, the presence of the reflex can also never rule out the torsion of testes. And this reflex is also absent normally in children less than 30 months of age. So the blue dot sign, this was part of the quiz as well. So it is the bluish discoloration of the overlying scrotum, overlying skin of the scrotum, mainly typical in appendageal torsion, seen on transillumination test. And the transillumination test is shining a light through the scrotum can cause the testis to, whole of the scrotum to illuminate. The translucency may indicate that it is a cystic swelling, such as hydrocele, or if non-translucent, then a tumor may also be suspected. So the points to consider when doing a urogenital examination should be: a consent should always be taken from the patient. Chaperone is a must and should always be present while conducting a urogenital examination. The procedure should be explained to both the patients and the chaperones. And having a chaperone in the examination room with us can also help minimize interruptions and protect privacy of the patient. So moving on to one of the DDs, we've got testicular torsion. So the incidence is usually bimodal, that is in children, infants below 1 year of age, and in children of 12 to 18 years of age. Patients typically present with pain around the affected testicle or lower part of the abdomen or inguinal region. And it is said that it is reported that twisting of up to lesser than or up to 180 degree usually causes venous impedance, venous outflow obstruction, and the swelling starts. And the torsion of more than 180 degrees can cause arterial flow obstruction as well. So there is usually associated nausea and vomiting along with the pain. And we can see that as shown in the figure, the torted testis usually lies in a horizontal plane as compared to the normal testes, and the cremasteric reflex is usually absent as well. So the causes could be, it could be idiopathic as well. It can simply cause in during sleep due to ipsilateral contraction of the cremasteric muscle, or in winter season where the cold temperatures usually induce contraction of the cremaster muscle. Trauma, a small percentage of patients with trauma can also present with torsion of the testes. And the congenital deformity, also known as bell clapper deformity, is an inadequate fixation of the tunica vaginalis to the posterior wall of the scrotum. As we can see in the figure on the right shows that the testis is in a horizontal lie, and the tunica vaginalis extends upwards and beyond, sort of enclosing the testis, which is mobile and has higher degree of torting on its axis compared to the one that is shown in the figure on the left side. So on examination, the affected testicle may be firm, tender, and higher than contralateral testis in a transverse lie. The cremasteric reflex, as mentioned earlier, is typically absent, and the Prince sign may be negative. The management of torsion of testis is time critical, and emergent surgical consultation should always be done as soon as history and findings strongly suggest a diagnosis of torsion. No radiological imaging or any test should delay this referral, and ultrasonography, if done, may show a torn testicle to be hypoechoic and enlarged. A color Doppler of the testes usually shows reduced blood flow to the affected side. Urine analysis may sometimes show pyuria, but it is not always present. Like management, as I said earlier, this is a time critical event, and time is testicle. So immediate surgical consultation should be done. It is reported that patients presenting within 6 hours of onset of pain, if surgical intervention is done timely, then up to 90% of salvage of testes can be accomplished, and less than 10% chance of subsequent atrophy is there. Every patient presenting with pain, analgesia should be the main priority as well. So systemic analgesics can be given, or spermatic cord block should also be performed if to achieve a good degree of analgesia. And a manual detorsion can sometimes also be attempted for pain relief and when there is delay in transfer of patients, but no mode of management should ever delay referral to the surgical specialty. So the figure here shows manual detorsion. Like I said earlier, it is usually done to achieve pain relief, as well as when there is urgent surgical consultation is not available. So as shown in the figure, torsion usually occurs towards the midline, that is in the medial direction, and detorsion should always be attempted in the direction opposite to it. As shown in the figure A, the right testis looks to be torted and is in a horizontal lie with some shortening of the spermatic cord over there. So the testis is considered to be rotated medially. So detorsion maneuver should always be done towards the lateral side. The detorsion maneuver should take place in two planes, that is from caudal to cranial as well as medial to lateral simultaneously. The Immediate pain relief is seen if the detorsion maneuver is working. If there is increased pain or no pain relief at all, then we might need to consider that the testes might have torted laterally, and detorsion should be done in the opposite direction then. So attempt for manual detorsion should never delay surgical consultation and referral, and it is not done as part of routine part of management. So this is a graph here that shows that proves that testicular torsion is a time critical event, because it is reported as seen in A, the bar graph A, that testicular salvage rates increase if the intervention is done within 0 to 6 hours, and subsequently decrease as the time passes. And subsequent atrophy is also reduced if in patients who had an intervention done within 0 to 6 hours, and atrophy increases along with time as well. So moving on to appendageal torsion. So testicular appendage is a pedunculated mass that is a remnant of paramesonephric duct, also known as hydatid of Morgagni. It is located in the superior aspect of the testicles between epididymis and testes. The incidence of appendageal torsion is usually in 7 to 14 years of age. So the clinical features are the patient may present with scrotal pain, might have mild symptoms with gradual onset. Patient usually presents after 48 hours of onset of symptoms. Associated symptoms such as nausea, vomiting, urinary symptoms, or fever may or may not be present. After several days of ischemia of the appendage, they usually undergo necrosis and eventual reabsorption. Hence, they do not usually affect fertility and impact the surrounding structures. So on examination, the hard 2 to 3 millimeters of nodule at the upper pole of the affected testicle may be noted. The entire testicle is usually not tender, and there might not be any overall change in size, and it does not typically swell until late in the disease process. So the cremasteric reflex, as we discussed earlier, is typically intact, and a blue dot sign may be present on transillumination. If the management is, if torsion is ruled out, then surgical excision is rarely necessary. Treatment with scrotal support, ice compression, and NSAIDs can always help. The resolution is expected in around 7 to 10 days. Surgery should only be reserved if there is uncontrollable pain, with all the things that we mentioned earlier. So moving on to epididymo-orchitis. It is the swelling or pain from epididymis or testes lasting less than 6 weeks in duration. It most commonly occurs in adults of 18 to 35 years of age. So it could be caused due to local spread through urethra or bladder, mainly in 18 to 35 years of age, sexually active males, participating in intercourse with other males. This STIs are mainly implicated, which usually are chlamydia trachomatis and Neisseria gonorrhea. And in the epididymo-orchitis can also occur in infants, which is usually idiopathic or maybe due to neurogenic bladder as well. So when the child strains too much during urination, there may be reflux into the ejaculatory ducts, causing epididymitis. And in adults more than 50 years of age, there is usually lower urinary tract abnormalities, such as enlarged prostate, instrumentation done or catheterization done, which makes them, which predisposes them to epididymo-orchitis as well. So there could be systemic spread as well through bloods and lymphatics. And the non-infectious causes may include drugs such as amiodarone, vascular diseases such as Behçet's syndrome, and autoimmune conditions such as sarcoidosis. So the clinical features as suggested is gradual onset over days. There may be tender swelling to the affected testicle, overlying skin changes such as erythema, associated symptoms such as fever, urethral discharge, urinary symptoms, systemically unwell patient with epididymo-ORCHITIS might need admission, and the complications may include abscess as well. So moving on to examination finding investigations, urine dip should always be done in patients which may be evident of pyuria usually. Urethral swabs and serology for chlamydia and Neisseria should be sent if sexually transmitted infection is suspected. And testicular colored duplex ultrasound might show enlarged epididymis with increased vascular flow. So management would be antibiotics as per local policy, scrotal elevation, localized therapy, and oral NSAIDs, IND or orchidectomy in cases of abscess formation, which is usually a urological management. So this table here is taken from our antibiotic policy over at DBTS. So under 35 years, usually sexually transmitted infection is suspected. Hence, single dose of ceftriaxone and oral doxycycline should be given. If allergic, ofloxacin can be used. And in over 35 years of age, usually enteric organisms are suspected. Hence, ciprofloxacin is given. And if allergic, we will need to discuss this with the microbiologist. So this is one of the management algorithm for acute testicular pain taken from my ED as well. So if torsion is suspected, we will in children we will need to refer to Sheffield Children's more than 16 years of age. If in Bassett law, should be sent over to DRI. If in DRI, we will need to consult with surgical SHO or DRES or this specialty. And if infection is suspected, antibiotic protocol as per mentioned above should be followed. And if fever and worsening pain, any systemic illness, any signs of complications, the patient should be admitted. So moving on to Fournier's gangrene. So has anyone seen Fournier's gangrene or seen a patient with Fournier's gangrene? I can
Yes.
see. Can you tell me about the experience, Olu? Because I, for one, have never seen any necrotizing fasciitis or Fournier's gangrene. It's only.
It's horrible. It was, I think the patient was picked up in A&E actually.
Okay.
So it was cellulitis of the groin area and it spread to the whole area, to the whole scrotum and everywhere, and the anterior abdominal wall. So it's just necrotizing fasciitis. So that affects the scrotal tissue.
This,
Well, basically, the main diagnosis you can do it for NIES, even without touching the patients. If there is some suspicion, it's a very, very foul smelling, it's a pseudomonas and all that. And it almost is proven that it's going to be a FOURNIER'S. It's usually very, very foul smelling. It's a lot of necrosis, a lot of ulceration, could be a discharge. I've seen a couple of them. But it's just smells is very telling.
Okay.
This man
How sick are they normally?
This man came to Risa about 2 months ago.
Yeah.
A beard man, unkempt.
Is it a sort of resus level patient?
Yeah, with painful, very painful swollen
Yeah, it's a
scrotum.
proper sepsis.
You know what he said? He said he stood up and his dog put its paws on his things on the scrotum. That's what he told us, and we admitted to surgical ward. You know, it's a necrotizing fasciitis, but there was no skin gangrene still, so it was quite swollen. It's very painful.
Quite bad. Yeah.
We sent to surgery. Yeah.
I was going through the Google images as well. It looked quite horrible, so I didn't post it over here as well. So,
You can feel capitus, is it? You feel
Yeah.
capitus when you touch the scrotum. and
Yeah.
swollen tenders, so.
Yeah, the X-ray, the gas on the X-ray as well. That's just the diagnosis you can know.
It was 2 months ago. I forgot his name. It was
Yeah, I saw him in resource.
Yeah,
Sorry, in theater, Mr. Junja.
or you saw in theater, because we received them, in the cubicle where the gas machine is, in
Yes.
the trust bay, resource bay. So we received them over there.
Okay.
You were taken to theater then? Ooh.
Yes, it
So
was
what
very
did you
bad.
do in theater?
Yeah,
Oh,
that's the treatment. They do the debridement, Mr. J.
Debridement.
It's because it spreads in minutes, so
Yeah.
it needs to be done in very, very urgently. The patient I've seen, that was a long time ago, but it just eats away your flesh and all that
No,
fat and muscles very quickly.
I'm interested what they do later on, after debridement. Did they
Yes.
do skin grafting or what?
I'm not sure about that. Antibodies, very, very strong antibodies, lot of debridement. Probably skin grafting, I guess this will be, but usually it just eats away very, very quickly.
When I was a houseman in surgical department, so I worked with a very eminent professor. So this was a deprived area of the capital. So we did get quite a few of them. He used to rotate a flap from the abdominal wall to cover the scrotum, rotation flap, full thickness.
Yeah.
Okay, fair enough. So,
Yeah, so almost all the slides have been
yeah,
discussed.
so he said his dog put paws on the scrotum, you see. And the nurses were saying, oh, no, there's a woman there, is it? I should have. Okay, fair enough.
Continuing on, so necrotizing Fournier gangrene is basically necrotizing fasciitis of the perineum and external genitalia. It is a severe, rapidly progressing, life-threatening infection of skin and underlying tissues. So the risk factors mainly include male sex, who is diabetic, immunocompromised, or is an alcoholic or an IV drug user as well. So the isolates usually show mixed with aerobes and microaerophilic or anaerobic organisms, which may be gram-positive or gram-negative as well. The clinical features include the patient may be systemically unwell and may be triggering on sepsis as well. There is associated fever with chills and rigors, and the pain out of proportion to clinical findings should always tweak our interest into considering Fournier's gangrene. So the numbness of overlying skin may be due to infection of the cutaneous vessels, and some subcutaneous emphysema and overt necrosis are usually one of the late signs. So blood should be sent as part of the investigation cultures, inflammatory markers, LFTs, USNEs to see the baseline function of the patient. As mentioned by Dr. Aldaf earlier, USG or X-ray findings of subcutaneous emphysema as shown in the figure are pathognomonic for Fournier's gangrene.
Is it a male X-ray? Is it a male X-ray? It looked like a woman, is it?
I'm not really sure, Mr. J. I got it from Google. So.
I mean, it can happen in women as well, you know, but it's a woman X-ray.
Yeah.
Yeah, because the labia majora is equivalent of the scrotum.
Zora, very, very clever.
So now you're hearing from the specialist.
This was the best one among pictures which showed the subcutaneous emphysema really clearly.
It's a woman X-ray, isn't it? That pubic angle is wide.
Yeah, and so any investigation should not delay the management and referral, because the spread of infection is as rapid as 1 centimeter per hour. As part of the management, sepsis 6 bundle should be provided to the patients triggering on sepsis. Source control is usually surgical, hence urgent referral is needed. Concomitant management of the underlying conditions should also be done that might have led to the gangrene, and IV antibiotics as per local trust policy covering both aerobes and anaerobes should be given. So this is taken from the antibiotic policy as per our trust. Type 1 refers to in Fournier's gangrene of or necrotizing fasciitis of the trunk or perineum. Hence, tazobactam and piperacillin along with clindamycin should be given. If allergic, microbiologist should be contacted. So blunt trauma of the scrotum or testes can occur usually in contact sports such as football or basketball, rugby's, etc., or maybe entirely accidental and due to one of our misadventures. So the most concerning injury could be would be a testicular rupture along with hematoma, which may be intra or extra testicular. So if a patient hematoma is suspected, anticoagulant history is always important as referral to or consultation with hematologist may be needed on the subsequent management. With trauma, there might be cremasteric spasm, which may result in an incarcerated testicle, which is one of the urological emergencies as well, and usually is seen by empty hemiscrotum. And most of the testicular injuries will warrant a urological referral after the primary survey. So management wise, a CABCD approach of trauma management should be followed, even though the patient is in a terrific amount of pain and discomfort. Early analgesia should be given with systemic analgesics or non-pharmacologic agents such as ice compression, scrotal support, as mentioned earlier as well. And urological referral and surgical management is usually the it should always be done. So we're coming to testicular tumors. So it is the most common malignancy in young men with usually affecting 18 to 40 years of age group. The incidence is around 6 per 100,000 males per year. And the risk factors include infertility, undescended testes, descended testicles of patients with cryptorchidism, and gonadal dysgenesis as well. So the types of testicular tumors are maybe germ cell tumors, sex cord stromal cell tumors. However, 95% of the testicular tumor comprises of the germ cell tumors, and the most common one is the seminoma. So nowadays, the testicular tumors are also classified into seminoma and non-seminoma germ cell tumors. The clinical features include painless testicular mass. If some patients present with pain, which might indicate there might be some hemorrhage within the tumor. The mass is usually irregular, firm, fixed, and non-translucent. And the testicular tumors commonly metastasize to lungs and liver, and sometimes to bone or brain as well. The imaging part of investigation should be imaging with subsequent follow-up should be maintained. Serum tumor markers such as beta-HCG, alpha-fetoprotein are not usually raised in case of seminoma, and if it is raised, it might suggest metastasized non-seminoma germ cell tumors as well. CT abdomen and thorax should be done to look for any malignancies, and if clinically indicated, CT brain or bone scan should also be done. So the treatment is surgical, that is orchidectomy with radiotherapy. This testicular tumor has a good prognosis, and seminomas for one respond very well to orchidectomy along with radiotherapy, and non-seminoma germ cell tumors usually respond to orchidectomy with chemotherapy. So my take-home points are time is testicle in terms of torsion. So urgent surgical referral should be done, and the subsequent management should never be delayed. Surgical referral is the mainstay of treatment for torsion and gangrene. Analgesia should always be one of the priorities when patients present with testicular pain and swelling, and antibiotics should be considered in patients when infection is suspected, such as Fournier gangrene or epididymo-orchitis as well. These are my references. So any questions, or maybe should we go to the post test, please?
I've got something to say about testicular torsion in the pediatric age group,
Yeah.
because I think, I don't know if Mr. J can shed light whether there was an incident in the past because of the way we refer patients. They've got to go to Sheffield Children's, and in the case of testicular torsion, time is of cardinal importance. So
Yeah.
if the local surgical on-call team cannot only dealing with adults, how do you ensure that this kid is not end up losing a testicle? So what measures are in place in DRI and Bassettville?
I can answer this question because we have this problem quite often, especially out of hours.
Yeah.
So there's a bit of like a yo-yo, like a pillar to post from the surgical and whatever. Now, there's a clear policy in our trust. If somebody is under 16 and coming with testicular pain, and the other causes have been excluded because the people need to go to Sheffield from Doncaster. Of course, it's a bit further away from the family. So we have to be particular. And then, so then it need to be referred to the Sheffield Children's Hospital under 16. And 16 and above, must be referred to the, as Saurab mentioned in his teaching as well. So to the local surgical department. Now, there's a little bit help here as well. During the working hours, I mean, one is clear-cut torsion, is it? Because the pain is there, referred pain to the abdomen, people are vomiting, because the vascular pain is always out of proportion to the symptom and sign, to the affected organ. And the pain is referred to the abdomen, children are vomiting, the walking is difficult, is it? Because with each step it hurts. They walk bent over and holding that in the picture. So, I mean, there's no doubt you need to talk to the Sheffield, but there's something where you're not sure. Now, there are Dr. Jas Soni, the radiologist. So he is good in soft tissue ultrasound and stuff like that. And then you might request the ultrasound department to give a scan, ultrasound scan. Sometimes they refuse, is it? Because they say, oh no, it needs to be admitted before a scan. But if you are nice to them, then they might agree to scan. So in a doubtful situation, I think scan, though we don't believe it, but I think, the people who are a bit experienced, they can say that no, because it happened a couple of times. I asked Matthew, go through there to do a scan. So Matthew ruled out testicular torsion. He said, no, I'm pretty sure there's no testicular torsion. So that's help available as well through the ultrasound department. I think testicular torsion, I think the sure thing is we've been taught from the very beginning, opening up and seeing really. So that's the sure test, that there's no other, or you do the MRI scan then, to see the, blockage in the blood vessels. Fournier gangrene, I mean, it's fortunately rare in this country, because certainly I've seen this one patient in resus, but back home we used to see a lot, and real sort of typical, the skin is gangrene, people present late due to poverty, whatever. So, the testicle hanging out, and then our professor used to do a rotation flap there to put on there to cover it. Epididymo-orchitis, very common in here, and we see, few in a week really, so I think previously we used to send them, the gum clinic was just where the minor injury unit is. So we used to send from here to the gum clinic straight the way. So, they go directly there then, because it's a bit of element of STI. So then they used to treat, they used to contact trace and stuff like that. But giving antibiotics is no harm, but please also ask them to go to the gum clinic, because otherwise they will keep on infecting and getting themselves infected as well. Tumor, very common in young people, is normally painless thing, and so much so we have a campaign on the national television, recently. Certainly I watched this advert to examine the testicle as the self-examination of the breast. It's a devastating set of tumor. Sometimes the tumor is little bit and then it already spread to the brain and stuff like that. I think it's a very common in young people. Yeah, but overall good presentation. Well done, Saurab. Yeah.
Okay.
Is it time for the Kahoot again to close this teaching?
Yeah.
As in for this block, this testicular. Olu? We're back to Kahoot.
Boom, hi.
Hi. Martha, we just another couple few minutes just to close the MCQ for the block. And then it's your turn, okay?
Yeah, okay. How did you do the break or how is
I don't think we have time for break because we had technical issues in the first session.
Okay,
Yeah.
because I didn't, I'm sorry I couldn't be before.
No, it's okay. Olu, can we do the post teaching MCQ for?
Yes.
Okay. Is it the same code again?
No, I think I'm not sure. I think it's a different one.
Okay, can you turn to the page so that we can share the game pin?
Oh, sorry.
Yeah, previous a couple of people answer to send people home on painkiller for the testicle torsion, is it? Previous. How we down do here like that? No.
Okay, hang on. Let's go. 7103302.
We have 2 minutes to get in.
I'm there.
I expect everybody to get all the answers correctly. Otherwise,
Saurab have to come back.
Yeah.
Saurab have to go back to school.
Otherwise, you send testicular pain home, no?
So this is a test of Saurab now. No pressure, Saurab.
Yeah.
Guys, where's everybody else? Come on.
3,
Come in.
4, 5, 6, 7.
Unless everybody just actually are just online but not here.
All right.
Seriously, we have 21 people.
Yeah.
Are people struggling?
I'm trying to get in.
Oh, Patrick, do you just go online if you don't have the app on your phone? Just go to kahoot.it.
Okay, Jess. Okay.
Martha is going to get a prize now.
No,
you are not on.
I'm not doing the question, the MCQ because I just arrived. Then
Yeah, you can still do it. You're a doctor. Come on.
No, a couple of women in the past were first. They came first.
Ten, 9.
Mr. Janjua, I know how is another kind of pains very bad, but I don't know how is the testicular pain. But I can imagine how terrible is testicular pain. I can imagine.
Martha, you be
Any
careful.
pain is pain.
You be careful when you wish it's the 21st century.
I think we have to go.
10, 9, 8, 7, 6. Where's everybody? Should we start?
Give the prize to Olu. He knows all the answers.
Because I have the answers. All right, I start now. Ready?
Go.
Go. Okay, everybody answered. Wow. So everybody got that right. But the first to answer was Regina.
Testicular expert.
Oh, Regina came first, is it? Ooh.
Yeah, the first to answer, which is the blue dot sign.
I presume the wrong answer will be the
This
right
is the one you got wrong answer, Olu.
Yeah, but
You're setting us up.
It has been corrected. It has been corrected.
Ah, okay. And 4 people think they're clever.
So, Saurab, which is the correct answer?
The appendageal torsion, of course.
Appendageal. So the blue dot sign is appendageal torsion. All right. Okay. Tilak. Next. Again. The bell clapper deformity. Consider bell clapper. Yay! Wow, Saurab, be a good teacher. Prajwal is on fire, but Tilak is still on top. Remember, the faster you answer, the highest you score. Next. 2 more. In suspected testicular torsion, what should we do? Ultrasound, surgical referral, send home on some paracetamol.
Send home.
Wow. So everybody's happy now. Last question. Oh, Boone is now on fire, but Tilak is not letting go. Last. The following are causes of epididymo-orchitis: coliforms, Behçet's disease, sarcoidosis, everything above. Wow, everybody's happy now.
Okay, who's on fire? Who's on fire?
Yeah. Samia, Prajwal, and the winner, undisputable champion.
Must be Tila.
What is the prize, Boone?
Boone is
number 4.
And prize number 5.
Tap on the shoulder when we see you in the
It's
debate.
a scrotal sport.
Scrotal support. Boone, please present the scrotal support to Tilak.
I think the questions will be different one in the post one, isn't it?
That's what I thought, but
yeah,
the presenters wanted the same question. So maybe in future we'll talk about that. Over to you now.
Okay, thank you very much. I think that closes the Saurab's teaching. I'm going to stop recording.